I guess I'm going to talk about it from two perspectives. Number one, decision-making, maybe on the initial case itself, which we all know what we did, but my task was to talk about short segment type fusion, particularly lateral. Thanks to the course directors. Thanks, Scott. I didn't know that was your case. Although I have various disclosures, maybe the most important one is that I was trained by Cliff, and so a lot of my thinking evolves from him. So with that, we'll probably come to similar agreements. When we take a look at this index case, if I'm to distill all this history down, this truly is not a deformity case, right? This is monoradiculopathy at L2 and L4. It just happens to happen at the same time, which is a little unique. I don't think I've seen that very commonly. So the first question is, what is the smallest thing that I could do to resolve this patient's complaints? And even before talking about fusion, looking at this patient with really kind of minimal instabilities, can you achieve foraminal decompression and resolve the radiculopathy without even thinking about fusion? Maybe. I think it would be a little bit heroic, right? We're talking about over-the-top, foraminotomy, maybe endoscopic. And at the end of the day, that is probably a temporizing procedure, right? But in the wise words of Dan Schuba, every disaster began with a high five. There really is no definitive procedure, right? So you want to do the smallest thing possible to resolve the patient's complaints. And we're all very highly trained now. We can do these advanced lateral, prone. And what I'll say is that at the end of the day, you should come back to those basic principles. So let's take a look at the index case. This patient has a lumbar lordosis of 58 degrees, but their pelvic incidence is fairly high. If you look at their L4 to S1 distribution, 45 is probably right about where they need to be. They do not have a lower lumbar deformity. They probably need to make up a little bit in the L2-3, L3-4 section. And we don't have an SVA. We were asked to assume that it's fairly normative, and it's a minimal coronal deformity. But take a look. What's abnormal? Their pelvic tilt. 42 degrees, right? So you take a look at that, and there's deformity elsewhere. There is upper thoracic or thoracolumbar junction deformity based on these x-rays. Probably upper thoracic spine is driving this patient's retroversion. And so when I'm thinking about resolving a monoradic and not doing heroics and taking a look at this, I think a multi-level lateral is probably a very reasonable operation with minimal morbidity. And the question is, are you burning any bridges while you do this, right? I always think about trying to preserve corridors in patients who are going to be treated maybe in the future and develop deformity problems. Another thing, having known the outcome, probably hindsight is 20/20, but you take a look and maybe there's a little bit of abnormality in that right spondy to begin with. So maybe my only criticism was at the beginning, I might have CT'd that and may have chosen to include the L5-S1 disc space, not to restore alignment, but only to span across a potentially unstable segment. So when we go back, what do we need to accomplish? Again, neurologic decompression through indirect means is appropriate. Correction of structural deformity, really not that much of a structural deformity that they think you could get it really anyway, lateral, T-lift, posterolateral, and reduce the burden of potentially temporizing surgery. For those of us who do lateral, I think you would agree that like a 2-3 level lateral, perc screws, is a very reasonable operation. Still a big operation, but a reasonable operation for a patient to recover. Just as an aside, I think understanding of optimal spinal alignment truly does exist. Vertebropelvic angles, which have been highly popularized. I think this is a paper that is definitely worth reading and understanding, and then not understanding, and then asking yourself why you don't understand it. But the take home for me is that when you look at pelvic incidence along a spectrum, L4 to S1 actually didn't vary that much, right? So at the end of the day, even in the patient with PI 86, probably don't need to be super hyper-aggressive or do anything heroic again. And another thing to note is that revision fusion does not do well as a primary operation. So we do want to try to define and try to design an operation which will not result in a fairly rapid catastrophe. Now, Cliff is going to argue, maybe for a T10 to pelvis or something longer, but really at the end of the day, he's pretty normatively aligned. It'd be nice to get a little bit of L3-4, and anything long segment, it's probably going to be tricky because the structural thoracic curve, which we're not seeing, is likely driving his elevated pelvic tilt. And so you may think about a smallish large operation. That might be upper thoracic. One thing also to consider, Scott was able to get a 4-5 XLIF. I don't know if he did it through an ATP. I take a look at this, and this is probably like an ATP at the 4-5 level, and 2-3 and 3-4 was reasonable. Laterals to treat this, obviously, other speakers have talked about this: decreased DBL, decreased length of stay, decreased OR time, decreased morbidity. And if we go through the MISDEF classification for this index case, I didn't realize I was necessarily supposed to comment on the after, but I can very quickly. This is a class 2, and in a class 2, such as this patient relieving foraminal stenosis, I think this is an ideal case. Now, when you look at the failure distally, I don't know if I have the slides, but if you look at our particular case in the failure distally, I think the answer is fairly equally easy. That's take the level that's unstable and add distally with pelvic fixation across the lumbosacral junction. So speaking to both, I know there's a big height difference between us accentuated by this mountain, but do you really want a long segment for everything, or do you want a short segment by a short king? Shout out to Dom.